So, esteemed faculty, thank you so much for coming, and I'm going through you or ask one person, so it will differ a little bit. We are talking about performing primary TKA in difficult situations. And first of all, the question is, what is difficult? Even an obviously easy case can be difficult if you try to solve it. Of course, there are some difficult cases, like this lady from Iran. She came to me in this situation, severe rheumatoid arthritis, small, can you do there? So many questions behind it. As you all know, I'm here in India since 20 years, so many times. I operated a lot. This is one patient I operated in Bangalore with this X-ray. This is quite a difficult primary knee. To be honest, these kind of knees you don't see, at least in Germany, and I think in US as well, not. Or this young lady who had two problems, this plastic hip and this stiff valgus knee, as you can see here. In my opinion, this is a difficult knee. Post-polio cases are also quite difficult, not really difficult. They seem to be difficult, but if you have the right implant, you can solve these problems a lot. But it's not only in India that you have these problems. I'm operating a lot in Latin America. Here's Sao Paulo case with a severe hyperlaxity, the primary case. What can you do here? You see the hyperlaxity, the hyperextension. Another case from Sao Paulo. This is a case from 2008, operated in Santiago in Chile. So these are, of course, very difficult cases, but most of them, I showed you, have an easy solution. Because, okay, hinge knee is probably the answer in all of these cases, but this is not what we are talking about here. First of all, I go very quickly with you through some questions regarding planning and preparation of the patient. First of all, BMI, this question comes always up. Let's go through the panel. I will ask you, Bill, do you have a cutoff regarding BMI?
No, I don't have a strict cutoff regarding BMI. I mean, they have an increased risk of wound problems and infection, but they get good pain relief and good satisfaction. So okay. I don't have a strict cutoff.
So there is no BMI 40 cutoff or 50 cutoff. So
well, I don't see patients that big.
They are quite rare in Australia, I guess. Yeah, okay. So let's go through my list here. Anup, do you have a cutoff?
No, so apart from the BMI, Thorsten, I think other factors are as important. The age of the patient, the overall mobility, the bone density, metabolic syndrome. So I think it's a complete comprehensive evaluation of the patient, just not the BMI.
Okay. Dr. Chatterjee. Dr. Chatterjee?
Yeah, hello. So I think I would like to keep a cutoff at 35, but I think there are two other important factors to be considered. The first is that how symptomatic is the patient? Does it warrant, pushing the frontiers of the BMI? And the second is that what are the realistic chances of this particular patient losing weight? So I think these are two other issues which we need to address.
Yeah. Dr. Vitri Kumar?
Yeah, hi.
Hi.
So I don't have a cutoff, but in general, if the patient has BMI more than 40, I might still talk to them about going for a bariatric surgery, but then that's something, it's a decision which the patient has to take. If they are not really keen, then probably I might still go ahead and perform. Yeah.
Dr. Logani?
Yeah, apart from what already has been said, I think I would look at the morbidity of the patient. If the weight is the primary limiting factor to the motion and not just the knee pain, that has to be assessed carefully in a counseling session. Then I would rather tell the patient to go for a bariatric first. If the patient is otherwise morbidly obese and at a really, really high risk of undergoing surgery, then also this is the kind of patient I would tend to avoid. Rest all patients we would accept with appropriate precautions.
Okay, so that means there's a clear tendency away from the BMI, just the BMI, so more for an individual decision in our patients. So any kind of nutritional assessment preoperatively in all cases, not only the difficult cases.
Yeah, so Thorsten, just to let you know, in the previous session we've covered a bit of this.
Okay,
so you
then
can
I
go
skip
through
this.
your conclusions.
Then I skip this. But this is even for primaries and difficult primaries.
The tranexamic you can take because I think that's something we didn't cover.
Okay, tranexamic acid. I mean, it's an old story now, but Dr. Marotti, tranexamic acid in all cases?
Yes, in all cases, local infiltration.
Any exclusions, any exceptions where you don't give it?
We have been told by our anesthetist to avoid it in chronic renal failure patients, CKD patients, because this is excreted through the kidney. They even tell us to avoid putting it intra-articular, local infiltration in those cases. Rest most cases we take up.
Bill?
Yeah, we use tranexamic acid intravenously at the beginning of the surgery, 1 gram, at the end, 1 gram, and then 1 or 2 doses afterwards. But recently we've started giving oral TXA on day 0, day 1, day 2, day 3, because there's recent literature showing there's benefits of 3 days of TXA post-operatively, and it's much cheaper orally.
Interesting.
I have a question here with Bill.
Yeah?
But we also give aspirin. Does it contradict Tranax and aspirin?
Well, I think they're different mechanisms of action. So the studies that, it was actually from HSS, a paper that showed less swelling and better recovery and they were using aspirin and TXA.
Actually, tranexamic acid stabilizes the clot formation. It prevents plasminolysis, destabilization of the clots. And aspirin is an antiplatelet. So both are different pathways actually.
That's true. So, Dr.
We have to
Chudari,
be careful in DVT patients.
DVD patients?
Yes.
Okay, but it's not really a contraindication, I guess. Okay, Dr. Chudari? Where's Dr. Chudari? Yeah. So exactly, yeah. And then we have Dr. Sharad. What about you?
Tranexamic acid?
Yes, tranexamic.
No contraindication.
No contraindication.
No contraindication.
No contraindication. Very good. And route of administration?
Intra-articular.
Intravenous?
Intra-articular.
Intra-articular.
Yeah.
No intravenous.
Intravenous also. But we ask anesthetist, but we give intra-articular for all patients.
But it's
same 100 mg, same dose intravenous, 1 dose.
Okay.
If required.
But it's an interesting approach of Bill from Australia. You give it now for 2 or 3 days or even longer. So we are keen to see your results later on. So local infiltration anesthesia. Everybody performs it in the meantime? Yeah, everybody. So let me always, or do you have any exceptions where you don't use it?
I don't use it. I don't use LIA. I used to use it, but then now I strictly adhere to ACB with IPAC block.
Okay. Any other opinions about it? Do we have any exceptions?
We avoid steroid component in diabetics.
Steroid. Okay, that's interesting. Which cocktail do you use, Bill? Which cocktail do you use?
We just use a long-acting local anesthetic and in the skin, and then for the deeper injection, we add adrenaline to that.
Adrenaline and long-lasting.
Yeah, we used to put NSAIDs. We don't put those in anymore.
Okay. Steroids? No steroids, Bill?
Not in the injection. They give patients get IV steroids from the anaesthetists, but not in the injection.
I use steroid in all the cases except diabetic.
So, what ingredients are you in your cocktail?
Bupivacaine, normal saline, cefuroxime, adrenaline, and clonidine I add in bilateral cases mainly.
So cefuroxime is part of your cocktail?
Antibiotic, yes.
Okay.
It's a part of the cocktail.
So as I told, I don't use cocktails intra-articularly. But
you don't use?
Yeah, for the IPAC and ACB, my anesthetist give bupivacaine with adrenaline. Yeah.
Your cocktail same, except steroids will avoid in severely insulin-dependent diabetic patients.
Steroid, bupivacaine, normal saline, fentanyl, and sometimes dexmedetomidine instead of clonidine.
Okay.
The original Dr. Ranawat cocktail, MAC2, that's what I use.
We don't use steroids. We use bupivacaine, clonidine, adrenaline, normal saline.
Okay. And
except the steroids, the rest of them.
okay, perfect.
Can I make a comment about the adrenaline? When we first started using the cocktail, we had adrenaline. We were putting large volumes with adrenaline in the skin, and I saw 1 or 2 problems of wound healing that I attributed to the adrenaline. That's why I take the adrenaline out of the first 60 mils, because I think it can sometimes affect the healing.
I made a very similar experience with adrenaline, and so I replaced adrenaline by tranexamic acid. Then I have the local tranexamic acid in my cocktail. So, if you are performing a primary knee, especially a difficult primary knee, let's go very quickly through the line. We start at the end. Do you use robotics, navigation, or none of them?
I do the conventional way. I don't have access to robots or navigation.
I operate robotic in one hospital and another place where I do conventional. Depends on the patient.
Both robotic and conventional.
I use navigation in every single case, so whether it is easy or difficult will not make a difference. And I particularly recommend to all the surgeons, I mean, if they are not consistently using technology, then they should not pick and choose technology just for a very difficult case, because it might boggle them down sometimes. So it's rather better to stick to something you've been doing every day, even for difficult cases.
Good point.
100% robotics, image-based robotics in one and image-less robotics in the other OR.
Okay.
Right. 100% I use manual instrumentations, the conventional technique, because I adhere to Howell's caliper K technique. I know it's in the next session, but then that's what I use. So yeah, I don't believe in that.
Mostly conventional, primary knee, robotics.
Thorsten, I have to say I'm a little bit offended by you calling it nothing. Because it's not nothing. We use manual technique.
None of them,
years
okay.
of skill and training. It's not nothing. I use these.
None of them. I do nothing at all. So it's, no, but you are right. It's a semantic one. So, and before we start with the cases, just go through the line. Which kind of alignment do you prefer, even in difficult cases? We start with Bill.
I use start with mechanical and then I adjust it manually. If it's tight medial, I take a little bit more off the medial side to balance the knee.
Adjust it mechanically or anatomically. Nobody knows what it is. So next.
Mechanical.
Mechanical.
I've been doing mechanical, but then last 18 months I've switched to complete unrestricted KA.
So kinematic alignment for about 75-80% of patients, where the normal length and laxity of the ligament is still intact. For very severe cases, functional alignment.
Mechanical alignment with minor tweaks on the tibial side, and overall functional alignment is the final aim. Especially for difficult cases, I add on the gap balancing technique rather than just the measured resection technique.
So mechanical alignment with jigs and functional alignment when I use the robot.
Same, functional alignment when I use robot.
Mechanical alignment and adjusted mechanical, just depends on the ligament balancing. I would go through it.
Very good. So majority does mechanical alignment. The robot and navigation guys are preferring some kind of more sophisticated alignment cases, techniques. Let's start with an easy case. 68 years, female. You don't see them so many in here in India. I know they are coming later. Usually anterior knee pain, especially when stair climbing. It's just a warm-up case. Pressure pain at the medial joint line. So everything is clear. What would be your decision, or what do you like to ask for additionally to this information's Bill?
Well, there's preservation of joint space on that EP X-ray. You've told us there's anterior knee pain. On the lateral X-ray, it looks like there may be some patellofemoral arthritis, but I would want to see a skyline view. I think if you're doing a knee replacement on a patient that doesn't have joint space narrowing, the risks are high that they will be unhappy. But you've shown us the skyline view now. It looks like there's full thickness cartilage loss in the patellofemoral joint. So if the symptoms warrant surgery, this patient will be a candidate for a total knee replacement in my hands.
Total knee. Dr. Durrani?
Yeah, so MRI would be useful in these cases where the tibiofemoral joint space is still maintained and the alignment is still maintained. Yeah, so we have the MRI here. Yeah.
So, Dr. Logani, what's your opinion about this case?
If I would avoid performing a surgery, particularly if the weight-bearing aspect is not that painful. You said we can elicit tenderness on the medial joint line, but that is a sign, that's not a symptom. So if the patient is himself complaining of weight-bearing pain, I would consider a surgery. Isolated patellofemoral pain, patients would be unhappy generally unhappy, I would say, not always.
Dr. Vijayakumar, do you agree?
Sorry.
Dr. Vijayakumar?
Yeah. All right. So, I mean, pure patellofemoral arthritis, I would, if the patient is pretty symptomatic, I would definitely go ahead and perform a total knee replacement, a medial pivoting total knee replacement, because I'm really sure that I could recreate the natural kinematics. And I would also resurface the patella in this kind of selective cases.
Mm-hmm. Dr. Marotti, if this would be your patient, would you prefer a total knee or more a PFJ, patellofemoral joint?
No, total knee.
Who would do a TKA in this case? Who would just do a patellofemoral replacement? Okay. So, and would you replace the patella resurfacing, TKA with patella resurfacing? Just raise your hands. Who would do it? Okay, and not? Who won't do it? No patella resurfacing in this case? Okay. Here I did it as an exception. Usually I never do it. Another easy case, a patient comes to you complaining, pain, discomfort, etc. So is this an easy case, Dr. Sharad?
There is a mild valgus. We have to see full length tibia.
Okay.
Otherwise it looks...
Tibia?
Also femur.
Also femur. Okay. Is this an easy case again now?
It is not the easy case.
It's not an easy case. So what would be your solution, Dr.?
In this situation, first will be correction of the deformity, and after that, maybe 6 months, 1 year, I would recommend surgery if they come back again.
So two-stage approach?
Two-stage, yeah.
Two-stage approach. Who would go for the one-stage approach? Nobody. Should we do the correction osteotomy, Dr. Sharad?
Femur.
In the femur, yeah. At which point? In which
okay.
location?
So at the cora, we calculate and do the correction in the femur. But sometimes these patients, after the correction, this knee pain will subside. They will not come for knee replacement.
Bill, how would you do it? How would you do the correction?
For this patient, I would do nailing.
I mean, Bill was a nail. You said was a nail, Bill?
Yeah, so the deformities in the femur, it's quite true that if you correct the deformity, the knee pain may go away, so we may not need to do the knee replacement. I would do a intramedullary nail, starting at proximally at the trochanter, and you need to do your osteotomy through a small incision at the site of the center of rotation of the abnormality, so the cora. With a small incision, you'd use fluoroscopic on a traction table fluoroscopy to make sure that you get to put your screws and to visualize the osteotomy and that sort of thing. And it's very important to be careful about the rotation. It's very common to get the rotation wrong. So commonly these are fixed in external rotation. So you need to understand the rotation and try to get that correct.
I would like to take the opinion of my deformity correction colleague, because those guys actually can calculate the Coran very accurately, and there is role of Elizarov in these kind of corrections.
Exactly.
So I would definitely like to take that opinion.
I think I would go for an Elizarov, that just do a corticotomy and it will be a very, very minimally invasive surgery and do a gradual correction with the Elizarov.
The recommendation for this type of patient is to do Elizarov, but because this is in femur and little in the upper part, doing the Elizarov in that part will be difficult. But as Dr. Anup Jurani sir told, I would take opinion of this thing. So only I told Neeli.
Actually, we can do a corticotomy even without doing an Elizarov. When we put an intramedullary guide wire for an interlocking nail, we stop just short of the cora, open up the fracture site, and we can do a corticotomy there without actually doing an osteotomy all the way medially. We break it open. At that point of time, iliotibial band will become very tight. That is the only hindrance at that point of time. You have to actually release a lot of iliotibial band and then correct the deformity, pass the guide wire in the distal fragment and put a nail. And this avoids rotational non-conformity also, because we are not breaking the far cortex all the way.
Can I ask the surgeons that want to do an Elizarov technique, how long do they need to wear the external frame for? And would you like to wear a frame like that for that period of time?
No, but I mean, you can argue both ways, but it works very well actually. And the patient need not be immobilized. They can walk on the frame and they can do their everyday work.
My opinion would be in this case.
This patient also would be having some shortening. So we don't have both the sides, but the shortening also needs to be calculated, which can be tackled very well with Elizarov.
Absolutely. So I did it in another way. I used the plate, not very well done, to be honest, but it worked, and later on he got his joint replacement. That's another patient, 74 years, male, instability and varus deformity. Difficult case, Dr. Maruti?
I need full length X-ray.
Full length, okay. More investigations.
Yeah.
What would you go for? What would be your plan? What kind of implant? Any correction before osteotomies?
In medial defect is there. So my preference plan primary PS knee, and I will keep ready TC3 kind of thing.
Who would go for a more constrained one? Okay.
It depends on the finding on the table actually. But you'd like to keep a constrained implant available.
That's true. So I did it without a constraint, with a PS knee. Instability. Here you see a patient, post-traumatic case, 2003, and he came, then next 2020, severe deformity, and then he came to me 1 year ago with this situation. Dr. Sharat.
I'll do hinge knee replacement.
Hinge knee replacement. Yes. Any other recommendations?
No. I don't think he should be given a choice of hinge knee right at the outset. I think depends on the findings on the operating table. But I think this can be tackled with a PS knee. Only thing we have to be careful is the slope on the tibia, which we don't have to replicate, but we have to give a 3 or 5 degree slope. And then I think the knee can be balanced.
One point I would like to make.
Attachment at the patellar tendon attachment is very flimsy. That is one thing, that's why I was thinking.
Yep.
I think before we jump to surgery for such patients, these are particular patients where we would want a vascular assessment, because we've had a couple of cases in the past where the patient limb was functionally vascular, but after doing an DSA, we found out that the posterior vessels were absolutely tethered just behind the femur and the tibia. and it was such a deep kink that without involving a vascular surgeon, doing the surgery could be actually dangerous.
Fortunately, I had no problems with the vessels, but I absolutely agree. I have seen some other cases as well. So I used a pure hinge in this case, not a rotating hinge knee, to get a maximum of stability. Deformities, as I said before, deformities, really severe deformities that you see here. I got this from Arun. We don't see so many in so many cases. So what's about this? This is quite common in Germany, extraarticular deformities like this. What would be your plan, Bill? If you have such a patient.
Is this Paget's disease, or what was the cause of this deformity?
It's not a Paget. It's not. I don't know, but it's not a Paget.
Well, your options are the patient has arthritis in the knee. I presume they have knee pain. So the options are to do the knee replacement without correcting that deformity, or to correct the deformity, and that may require even a 2-level osteotomy to correct that femoral deformity.
Where are the levels that where you want to correct it?
Well,
on which level?
You've drawn the lines there, so you'd do either one osteotomy where those lines cross, or if you needed to, you could do 2 with a nail. My colleagues are probably going to want to do a Lisroff. That would probably work as well. But I'd be looking at whether I could just do the knee replacement.
This is a very common, this is a very common finding in India where the patients have got bowing of the femur. So this is not post-traumatic deformity. And this is less than 20 degrees, what I can see from my eye. And if you draw the axis, then this will not touch the lateral collateral insertion. So I think this can be corrected intra-articular and with some technological assistance.
I think we would like to accept a little bit of undercorrection in such cases. We are doing intra-articular correction, but leaving it a little bit undercorrected won't do much harm, and it will certainly not violate the collaterals.
So is there any cutoff? I mean, you said 30 degrees. Here it's I would say around 20 degree, 18 degree. So where is your cutoff? 15 degree, 20 degree, 25 degree to do an extra-articular osteotomy or correction instead of an intra-articular?
From the mechanical axis of the femur and tibia, if it crosses, as Dr. Anup Jarani sir told, if it is above the lateral collateral insertion or medial collateral insertion, then that cutoff we will not take. Okay. Otherwise, we take the cutoff.
I think the cutoff cannot be just labeled in terms of degrees. It is also labeled in terms of how closer to the joint is the deformity, and what is the length of the lever arms that we are dealing with. A very long lever arm, a very small degree of deformity away from the joint won't matter much. But if the lever arm is shorter, if the deformity is closer to the joint, then we would think about more corrections.
So I did this in a one-stage procedure, nail and combined deformity, again, 80, and it's a very similar case, 80 years, 25 degree varus deformity. Extra or intra-articular correction?
Intra-articular, but I would put constraint, semi-constraint. Because there is a varus thrust, there will be, so intra-articular.
Okay. But very good. Another proposal, intra-articular. I did the same intra-articular. You can leave a certain deformity, especially in patients who are 80 years. What here is a deformity for the tibia, after tibial osteotomy, where you can do this extra-articular correction. Some other cases, this was done not by me, by a friend of mine, but for this, do you think you use a robot or navigation system, or you can do it in a conventional way?
It can be done in a conventional way, but it will be a little cumbersome. You need to use an extra-articular jig and have the X-ray machine inside the operating theater. That way it can be done by using conventional techniques.
Yeah, for me, typical case here for a robot one. Extra-articular, we see, and then here I come to the end. The solution of all these cases I showed you were hinge knees, and my last question for you is, and we go down the line, and then we finish this session. We start with Bill. What is your indication for a hinge knee in difficult primaries?
Well, a hinge knee is good for instability, so I think it depends on the integrity of the collateral ligaments is the main thing.
What about bone loss?
Well, bone loss can be addressed with augments, so it's more about the collateral ligaments.
Yeah, same. Intraoperative, after trial, we just assess in flexion and extension. If mid-flexion instability is there, we should go for the constraint like TC3 or hinge.
Okay. Same, it's instability or neuropathic joint like Charcot's, then my indication is going for a hinge knee, but not for severe varus or valgus cases. I try to avoid getting into the constraints because I'm pretty sure I can manage it pretty well with a CR knee or PS max.
When one of the collaterals is incompetent, say MCL or LCL, or there is a severe mismatch between the gaps and the flexion gap is much bigger than the extension gap.
Same, but for hyperextension, I would be a little more inclined to prevent this recurrence.
Eng type 3 bone loss, which involves the attachment of the collaterals, number one. Number two, severe valgus with medial tissue sleeve disruption. And third would be a hyperextension deformity.
Same as.
Similar, it's mainly for instability. If I'm doubtful about the integrity of the ligaments, I'll go for a hinge.
Yeah, I agree with all of you, but I think don't forget the flexion gap. If you cannot control the flexion gap, probably it's a good solution.
Can I ask a question in that just last X-ray? What I notice is that the two stems are very close to each other.
Know.
Are you worried about a stress riser there?
Yes. I did this case 2018. I saw her last year in Istanbul. She is fine, fortunately, but there is a high risk, especially because as it would. But in my opinion here, the alternative in 2018 would be a total femur replacement to avoid it, because I needed the stems, but that's absolutely true. There is a risk of interprosthetic fracture.
Any way to avoid this situation?
Yeah, I did in a very few cases. I did strut grafts in this area just to strengthen it, but nobody knows exactly what is the main risk for interprosthetic fracture. Is it the length of the gap, or is it more the cortical density and strength? And many people are saying it's more the cortical density and strength, but I agree, rheumatoid patient, it's not really strong.
Just last question. Will it help to apply a periprosthetic plate across the junction?
Yeah. That's another option. It's another option, but then I would do always, as I said, with the strut grafts, a double plate or double strut graft, never alone. Thank you so much, my friends.